Thank you, Tony and Richard. One thing I can promise you is that we will be spreading the word and keeping people informed. I mean, everybody that comes to my clinics will know they go away with a handful of leaflets and information. And you've alluded to this great change, this turnaround, and I'm going to come on to that a bit later and just expand a little bit on that, because I think you're absolutely right. We have turned a bit of a turning point. There is vast amounts of money going into the research in this, which is good. But in preparing for this talk, and I noticed some of my patients in the audience, I've been asking the patients, or asking our patients, what is it you want to know? What questions do you want to ask us? What would you people want to know? So I've been asking people for quite some time about what they would like to know. And surprisingly, very often, it is the simple questions like, what is macular degeneration? What is the difference between dry and wet? And also, what's the latest research? And I do encourage my patients to bring along the newspapers with the latest articles, which tend to tease us with things that are promised and coming on. So this morning, the next 40 minutes, what I want to do is just work through those, and then there'll be some time for some questions at the end of it. So, macular degeneration is not new. Amazingly, it was first described well over 100 years ago. 1875, Hutchinson described a condition of bilaterally atrophy, bilateral scarring in the back of the eye. So it's not new. But it was really only when the very first sort of treatments came in about the year 2000 that some of the new treatments came on. And it's relatively recent that we've had treatments that have been effective. You will all remember the cold laser treatment that started off first of all. And then in the 2005, 2006, we've been having the new biologics, which many of you, I'm sure, have been having. And we'll come on to what's going to happen after that. But we'll take one step back and sort of ask, well, what is macular degeneration? And how, despite all the publicity we have, despite the television and things, there are many people out there that still haven't heard of the condition, which certainly is a problem. If you begin to lose some vision, you assume it's your glasses. Well, we well know that that's something you mustn't assume. I always say, and often are heard to say, that my 90-year-old patient can see the bottom line of the chart. If you can't see the bottom line of the chart, you have to ask why. Why can't I see that? And there will be a reason. And that's for us to find out what the reason is. So I often describe the difference between dry and wet between like a pair of jeans. Most of us, not in this audience, but most of the people out there have normal retina. Their genes are nice and clean, they're nice and pristine, and that's a normal retina. So what can you do? What can you advise your friends, family, children, etc. to do to protect their retina? Well, one thing is protect your eyes from the sun. It's known that light is toxic, especially blue light. So shades for the day was one thing the blind dogs out there did. Children, fortunately, it's cool to wear sunglasses, so that's good. Protecting the eyes against protecting the eyes against light with sunglasses is good. Having a good, healthy diet is important. We're all told vegetables and things are good. And having your eyes checked regularly at the opticians, having a photograph is good. Picking up those early signs is very important. There's no point in taking additional vitamins if you've got a normal retina. That does not help. There's no point wasting money on that. The important thing is have regular checks. So that's most of the people who will have normal retinas and will not develop macular degeneration. Then we have the people which I describe as having spots on their genes, little white spots. They're called drusen. Drusen is a word which means that they're little round, either small, large. They come in a variety of shapes and sizes, and everybody who has them, it is unique in their pattern. Not a great deal is understood from them, but they tend to occur after the age of 50, 60, 70, and they come all at once. They don't sort of have one this year, one next year. They represent the retina being under stress. They represent the wear and tear process. They represent, I always describe it as like the rubbish being put outside the house. It's the debris that can't be digested, the debris that the body can't deal with from all the busyness that's going on in our eyes at the moment, the busy factories turning the light into what we see in the back of the eye. And they are the waste products that build up, and they're the early signs that something is not quite right. And thus, What can you do about them? Well, at the moment you can't get rid of them. They gradually evolve from small little spots. Over the years we can now follow them. We've now got instruments that will record, will count the numbers, look at the volumes, and they tend to increase in number and size and then gradually fade away. They will either do one or two things. They can either fade away and just give you a bit of what we call dry macular degeneration, or they can develop your wet. So they're an important thing to notice, which your optician will be able to see with when they take the photographs. It's a very good thing that the opticians do to take photographs. Is there anything we can do to get rid of them? Well, there are trials going on. One particular drug, elucibab trial, which unfortunately was negative for the dry form, but they're looking to see had it any effect on the drusen. So people are looking to see whether there are any fat-type busting drugs that we can get rid of. People, at the moment, there is not a great deal you can do about it, apart from being aware of it. Vitamins, we will discuss a little bit later, may be appropriate. So that's drusen, little white spots on your genes. You then come to dry macular degeneration. I view that as where the retina, the genes thin and the fibers thin, and you begin to get a bit of an effect on the vision. What forms the dry form? And this is where still your genes are dry. They're not wet, they're still dry. What forms it? Why do I get it? That's a common question. Why have I got the dry macular degeneration? The answer is there isn't one answer. It's a multifactorial thing. Unfortunately, as we all know, it is something that happens with age. It's something that happens after the age of 60. So it's not a disease of young people. That will be your macular dystrophies. But it is something that happens with time, with age. Wear and tear, we often describe it. It's diet, yes. People who have poor diets are more susceptible to it. So a diet rich in vegetables, rich in vitamins, rich in lutein and zinc and all that sort of thing is protective. Smoking, well, we don't need to tell everybody that smoking's bad, but smoking is bad for your eyes. And if you can do one thing, that is try and tell children not to smoke. But that's a difficult thing to do. Light and genes. Genes have some role to play, but it's not a genetic disease, not like the macular dystrophies. It's not purely a genetic disease, but some people are more susceptible to it than others. The work evolved in the dry forms is looking to see, well, are there things we can modulate? Can we modulate the immune system, how the body reacts? People are looking at various proteins within the body. There are, at the moment, phase 3 trials which are the sort of trials just before you're going to launch drugs into a number of compounds, both steroids, long-term steroids, doxycycline, something we use for acne, simulocin, complements. So there are a number of trials at the moment that are going to look at the dry form, and maybe in the near future some of those might turn positive. Not all trials, unfortunately, turn positive, but there are trials going on for the dry. After the dry, some of the dry will progress on to what we call geographic atrophy. This condition is common. We commonly see it, but not very well understood, I find, with patients. And that, I view it where the genes get a large hole. There's a large hole in the genes. It's worn completely thin, and you've got a hole there where there is no retina. And that can cause quite a devastating loss of vision, and it just thins the retina. And unfortunately, if you take the retina, the film at the back of the eye, if you do make a hole in it, whether it's one of those little drusen which have dried away and made a hole, or whether or not, for whatever reason, even with a laser scar in diabetes, the edges enlarge and they get bigger and they get bigger, and the geographic atrophy spreads. And unfortunately, we see this in the clinic many times, that it gets bigger. We know why it gets bigger, because the little cells on the edge are eroding, just like the sea on a cliff, it erodes through. We can measure that now, because one of the things that has happened over the past 5-10 years with all the investment on drugs and the amount of money that's going in is that the imaging, the photographs, the OCT scans we have, the way we can image the back of the eye has improved tremendously. So we can measure that now, and we see people with geographic atrophy doubling in that area over the year. So now there are, obviously, if we can measure it, we can apply trials, we can apply drugs to it to see if it works. And there is lampivizumab, which is turned positive for reducing that growth overall. by 20%, which is a start, but certain groups of that, certain people with particular genetic types, are actually reducing that by 40%. So this is a drug that's been in phase 3 at the moment, MALO trial, and that's very encouraging. That's encouraging that just around the corner for the first time, it's probably the closest drug to market that we might have something that will help the geographic atrophy, which can produce as devastating loss of vision as the wet form. And people often ask me, which is better, dry or wet? It's an academic question because it depends what you have. You either have dry or wet, or you have both. But certainly the dry form of geographic atrophy can reduce your vision just to hand movements. So a drug which attacks that, which preserves the cells, stop them dying, stop the edges expanding, could have really quite dramatic results. So we await for that. So that's your dry, your drusen, your dry macular degeneration, geographic atrophy, 3 types, and the 3 words that we'll be using in the clinics. Then I say your genes have got into the washing machine. They got wet. And they're being washed, and that's what wet macular degeneration is. It literally means there's water within your retina, water between the cells. There may also be blood. There may also be lipids there. It's a dramatic change. And as many of you know, that's where the new types of drugs, what we call biologic drugs, have come in. And the drugs are evolving. We had the traditional drugs, your antibiotics, your aspirins, your steroids. They're what we call standard drugs. They're molecules. But the drugs that we use now, often termed by many of us as wonder drugs, because they really have transformed the prospect of curing this condition. I often like to say that we can cure it. That means we will control your wet macular degeneration. We will take those genes out there, put it in the tumbler dryer, and dry it up. And that's what we mean when it goes from wet to dry. Get those genes nice and dry. Unfortunately, they're still going to have perhaps some of the other dry forms. And we do that obviously with the three drugs we all know, the Avastin, the Lucentis, and the Eylea, all 3 of the drugs. And often I'm asked, so which is best? Which is the best drug? Well, the answer is they all work, and they're all roughly the same. Big randomized trials or in Europe and in America have shown that there's very little difference to choose between them. In America, 60% of people are using Avastin. In England, it'll be the other way around. But we use all 3 of the drugs all of the time. And to be honest, it doesn't really matter which one you have. It's getting that drug, which will then put the genes in the tumble dryer, getting it all dried up. But as you know, at the moment, these biologic drugs, the made of proteins, they're very, very delicate. You can't get them into the eye with drops. I'm often asked, can you have drops? Not at the moment, because these proteins will get digested if you put them on the eye. They have to go inside the eye. And obviously that is a huge resource that we have at the moment. And up and down the country, because of the volumes that are needed, many hospitals are doing 400 or 500 injections a month. We're getting teams of people. We're now getting nurses to do the injections. Perhaps some of you have had a nurse do the injector, and somebody was describing to me earlier that doctors are often very frosty in nature, but nurses are very touchy-feely, and not surprisingly, they're going down very well as injectors, and quite to my surprise, that technically they're absolutely fine, because after all, it is only an injection. I'm sure once you've had one, you realize it's not that a big a deal. And nurses are now forming a bit of an army to deliver this treatment, which is great. There's also, so what other treatments do we have? Certainly anti-VEGF will stop the progression. It can improve it, but it can't do miracles. It can't undo, as Tony said. We can't stop the condition. It would be nice to step back and stop it. So the most important thing is to pick up, detect the disease very, very early. And catch it early. That is a small problem, because the better we get at it, and now I'm getting increasingly, because of the awareness, because everybody is telling everybody about macular degeneration, the optometrists know about it, that we get patients whose vision's hardly affected. I often see now periodically patients that have been to the optician, had one of the OCT scans there that's normal, and this patient came for cataract surgery, and in between times, between going to the optician and seeing me, she developed wet macular degeneration. The vision was still very good, too good to have the nice guidance. And that does form a bit of a problem. You've got to have, as far as Lucentis treatment in the nice guidance, you've got to have vision not good enough for driving. But for those people, we, at least any rate, use the Avastin treatment, and we can keep, if you catch it really early, I've got quite a number of patients that keep at normal vision, keep at 6/6 vision, 20/20 normal vision. So if you catch it early, then you keep the vision. If you let it go on and you let it late and you can't see the top letter of the chart, then you're only going to be able to get a few lines down before you stabilize it. So the important thing which all of us can do is make sure people are aware of this condition, because catching it early is the absolute challenge. No matter, we have drugs that can cure it, and it's great to put money into research, but we've got things we can do here and now, and here and now is making sure that the disease is picked up early and people are then transferred to treatment early, so that we can, I say we cure it, because in my view, once I stop injecting, I've cured the condition. I might not have brought the vision back to normal, but at least we will have stopped the condition and they won't need any more treatment. And equally, stopping treatment is a good question. When do you stop treatment? We in the clinic do often get into this cyclical phase of seeing, injecting, but sometimes we have to ask the question, is it worth carrying on? And there are people that may be cured with just, say, 3 injections, 10 injections, 20, 30, and there are people who have had 50 or 60 injections. I'm not sure there's a Guinness Book of Records of the largest number, but I would like to know. I'd imagine it's in America, because America and English way of treating people do differ. In America, you have treatment whether you're dry or wet. In the UK, you have treatment generally only if you become wet. There is a bit of a difference of a philosophy between Europeans and Americans. The Americans like to have treatment just in case, and we like to have treatment only if it's needed. So there is a bit of difference on the numbers, but treating, when do you stop? And sometimes you have to ask the question. Sometimes I say to the question, there is scarring there, there is damage there which we can't cure, and is it worth carrying on? And sometimes it may be worth just asking that question, is it really making a difference? Is it really going to help my vision at this stage? Sometimes one has to just step back and say, actually, we've done everything we can, and it isn't worth carrying on. So stopping is for us quite a challenge. As we say, this condition, as you know, is a rapid condition, and the RNIB had a very good campaign, a very good television campaign, that you can lose your vision within 3 months. And sadly, that's absolutely what can happen. The earlier we treat, the better. Most of us have rapid access. Most of us have direct referrals into the clinic. Most of us have optometrists that know how to get the treatment in, and that's very important. The other thing to know, the key bit of information for you and your friends, is which opticians now have an OCT, the optical coherence tomography, a bit like an MRI scan of the brain. It scans, and all of you, I'm sure, will have had one of these scans, which tells us if you have macular degeneration. And you can't see it with the naked eye. When I look into a patient's eye, it can look normal, as it did in my patient coming for cataract surgery. It looked normal. I was surprised to do the scan. I just happened to do it because I had the scanner there to see that it's wet. And if you don't do the scan, you can't be absolutely certain, and that is the frightening thing. So a lot of opticians now, or perhaps not a lot, but a large number, are beginning to get these tests in, and it's worth having it. And to bear in mind that opticians have 2 tiers of eyesight tests. They have the standard test, the National Health Service test, and they have an enhanced test. Usually you have to pay for the enhanced test, but that includes things like the OCT scans, and it sees things it sees things that they can't see with a naked eye with the ophthalmoscope. So it's good to seek out optometrists that have these scanners that they can look in. How do we pick it up early? Because early detection is the key. I'd love there to be a national screening program, just like there is for diabetes, so that everybody is made aware of it, everybody has a scan, and that's certainly the beauty of going to the optometrists. Covering one eye, covering the other, checking that your vision's normal is the simple thing to do. But if you're already at a risk group, if you already know you've got a bit of dry macular degeneration or drusen, you're much high risk. How do you pick it up? And it is actually very difficult to pick up the early signs. Many of you will have seen the squares, the Amsler charts we use. they're pretty not very good, really. It's very rare for them to pick up the early disease, and we know that. So scientists have been working on, is there something else we can do? We've got computers. Is there something we can do with them? Well, there's a company in America called 4C, Home Monitoring, which is not yet over in the UK, but should be coming over shortly, which is a device that you check your vision once a week, and it gives you a little vision test, and if there is any change in that, it reports and alerts you to a change. With that, they in their studies and their trials they've done, they pick up 94% of patients using this that convert to wet, so that's most of them that did convert to wet in their 2-year study. They maintain their vision, whereas those that were just using the Amsler chart, it was only just over half. So that's the first time we've seen, for those people that are at high risk of developing macular degeneration, have something that can pick it up early. And if you can pick it up early, you can, like anything, nip it in the bud. So that's something just to be aware of in the future. So what else do we have? As far as treatment is concerned, a lot of people have been asking about radiotherapy, about AREA therapy. Radiation has been looked at for macular degeneration for many, many years. Usha Chakravarti, with her study of external radiation, wasn't helpful. We're all concerned that radiation may produce damage to the retina, but there is now the new treatment, the eye therapy, which a couple of NHS trusts are now taking on board, which for certain groups of people, especially people that need lots of injections, is proving promising, and they've now got 3-year results that were presented at our meeting only a few weeks ago, the European Retinal meeting, and I think that, just as this audience is full, the interest in retina is now huge. There were 5,500 doctors just specializing in retina from Europe at that meeting, which is the largest they've ever had, a huge number. It was 1,000 above what it was last year. So there's a huge interest in this. But to come back to the radiation, so AREA therapy is suitable for a few people, and it is beginning to sort of show some inroads into the NHS, and that's something to watch for. It's not a miracle cure, but it might just cut down on the number of injections, and it seems to be relatively safe. So that's radiation. What about for the end stage macular degeneration? Sadly, despite all this, for a variety of reasons, you may end up having, and the last part of macular degeneration, once you've gone from the dry, from the drusen, from the geographic atrophy, from the wet, is the end stage, which is where there's just a scar, and very often that's where it's going to stay. What can one do for end stages? Well, there is, of course, lots of support that you've seen outside. People are now trying to look at making the sort of visual performance of the eye better with little telescopes. So we've seen out there, we've got the implantable telescope, which will magnify the image at the back of the eye, improving it. And for certain people, that seems to be a technology which is now beginning to get into the NHS as well and beginning to prove successful. So for some people, if you haven't had cataract surgery, then that is an option as well. So one thing I think about that my patients do ask is the technologies. What's happening? Well, just as we've seen the optical coherence tomography coming in, there are newer forms of that. Many of you will have had the dye test, the fluorescein tests. The next generation will probably mean without dye. So there are things that are coming on and better imaging, which just means it's easier for us to manage. What about new drugs? I'm often asked, we're all asked, the newspaper comes along with a new article, usually just a snippet. Well, we've seen, as we said, we have the traditional drugs, we have the biologics. The next one is nanoparticles, nanotechnology. It seems to be a buzzword currently, and that is the next generation of drugs that is now being proved, or proof of concept. And several units around the world are looking at what we call nanotechnology. We've got Professor Kadira at Imperial Hospital, and we've also got Justine Haynes in the Wilmer Institute. Several places around are now looking at this. And what is nanotechnology? It's where you can take, I view it like a train. You have a nanoparticle, which is 1/1000th of a meter, and that particle is the engine, and you have your drug, which is the carriage. And the problem with drugs like Avastin and all of those others, if you put them onto the eye, because what you'd all like is a little drop to put onto the eye of anti-VEGF, so you don't have to have the injections. But you can't put it on the eye because, as we said, it gets absorbed. It will not get into the eye. It'll get washed away. So what you do is you attach it to a particle which you can design, a nanoparticle which you can design to actually go into the eye. You can't do that with your Avastin because if you change that particle to get into the eye, it won't work as a drug. But if you take a particle that can get into the eye, or you change that particle to attack a cancer cell, to attach itself to a cancer cell, or attach it to a particular bit, it can be attached to your drug, your Avastin, for instance, and then it can take it across the cornea. Once it gets into the eye, it can release, separate, and your anti-VEGF can float into the back of the eye, and the wonder drug will work. That's what nanotechnology is, and it's quite an exciting new way of thinking about it, a combination of the biologics and the science and chemical engineering coming together to produce a sort of new targeted delivery system. And the proof of concept has been done. So you might have seen the articles that were released earlier this year from Imperial about the fact that they've done that in rabbits, that they've managed to get the Avastin encompassed in a nanoparticle into the cornea and into the back. And that research is carrying on. Chen in the Wilmer Institute has done that with a drug we call axitinib, which is a very short-acting anti-VEGF. It has to be given every day. You couldn't have an injection every day, but you could have a drop every day. It's very short-acting, and it needs daily dosing. So attach it to a nanoparticle, it can get into the back of the eye, and they've already done that research in rabbits. So it's in the animal model. Now they'll need to look at the safety of it, first of all, to see if it's safe to give into humans, and then into clinical trials. I mean, this is transitional science working in combination with the pharmaceutical industry. So that's exciting. That's the next generation. So if people say, will there be drops, which I get asked, the answer is, I think there will be. I think there really will be in the years to come. There will be this type of technology developing targeted delivery. We heard a hint at gene therapy. Now, this is very interesting. This is now really evolving. We've coded the whole of the genome. We now know the genes for a variety of specific proteins. And it's a bit like, in some conditions, in dystrophies particularly, it's like making your bread. You know, if you don't add your yeast to your bread, it's not going to be bread. But you know that if you added yeast, it would be bread. So can you do the same thing with the cells in the back of the eye? Can you just add that protein that is required into the mix to make that cell work properly? And if you know what that coding for that protein is, if you know what the genes are that make that protein, then you can now design your own gene therapy. So what you can do now is take the ordinary cold virus, and I'm sorry, I'm just recovering from a bit of a cold, but you take the old cold virus, you take its shell away. The cold virus, the adenovirus, is very effective at infecting things, unfortunately, as we all know. And you then put into that your gene. You add a little bit of starter, a little bit of finisher to switch it on and off, and you put the code in there, and you wrap it around the viral capsid, and then infect the cell, and it gets into the cell, it gets replicated, that gene, that yeast, or whatever is required is then expressed. And that's what gene therapy is. Is it pie in the sky? Is it science fiction? No, there are trials. There are many, many. We heard some of the research only a few weeks ago. There are many different trials going on for different genetic conditions. Macular degeneration isn't a genetic condition, so it's not going to be helpful directly in that way. But some people question, why not make the gene create some anti-VEGF, create some Avastin in your eye? Well, maybe. People are thinking about it, concept ideas. So that's something I think certainly for the dystrophies and things, which is why maybe he will be able to see, Tony will be able to see his grandchildren in time because the genes can be designed. It's just in the infancy of designing gene therapy. And the delivery of which is, of course, relatively easy compared to that other pipe dream, which I get asked every week, is stem cells. Stem cells is a bit of a different kettle of fish. There was an enormous amount of work. Our own Professor Kevin Gregory Evans at Imperial went over to Vancouver, Columbia University, and has been doing groundbreaking work there with a tremendous amount of investment. And now stem cells have gone from perhaps, can they work? Well, they the initial stem cells didn't react to light. Now they can make the stem cells react to light. That's a good start. Stem cells came from, of course, the umbilical cords, and they're not very cheap and easy to find. Now people are talking about making stem cells from ordinary cells, either from iris cells, from fibroblasts, from various wells. So they're looking at the problems of, can we generate the cells? Can we make the cells from something that's sustainable? How do we apply them? And there's a lot of work about creating the cells and making them act the way we want them to act. And that's working very well. That is getting to the stage now where people are beginning to put the stem cells in the eye. And that's where the slight difficulty with stem cells comes, because in the technical aspect of inserting something is traumatic. And there's got to be a lot of work in trying to get stem cells in there. And then, of course, all the telephone connections to actually get to work to get the signals back. But there's an enormous amount of investment that's going on into that, and progress is certainly being made. It's not necessarily here and now, but trials are sort of underway. So that's stem cells. Surgery. Rotating the retina and major surgery never really caught on. Certainly the injections are much more delicate. But people are now trying to move bits of retina from one place of the eye to the other if the eye is severely damaged. And that is something that's progressing. The other thing we alluded to is the retinal prosthesis, the electronics, the Geordie visor type thing. Well, we've seen people who have had retinitis pigmentosa who do not see light or day be able to see the arches of Oxford University. And some of that research, groundbreaking research, is being done here in the UK, and trials of the retinal prosthesis in macular degeneration are now happening. So there are 30 patients that are going to have it to see, will those retinal prostheses work? Will they help? So that's something that's coming on into the future. So there's an awful lot that's going on at the moment, and it's quite confusing for you, it's quite confusing for us. But I think we will see in the next few years some genuinely new drugs for dry, which is going to give us a huge demand, and perhaps in the next 5 or 10 years, eye drops to treat the conditions, and that's fantastic. What advice do my patients also tell me I should pass on? Often I'm said the doctor didn't tell me anything. Well, I think one of the important things is when you go to your consultation, be a bit proactive. Write down before you go what the questions you want to ask of us. We never mind being asked questions, but write them down. Take a friend with you that can take a notepad and record what's being said, because 80% of what goes in this ear comes out the other ear. It happens to us all. And if we're a little bit, we may forget. So write it down. We don't mind that. For the very young, there's an app, My Doctor's app, on the phone, which you can just record the consultation. You're allowed to do that. That is perfectly GMC allowable, to record your consultation. Because what we say, we're proud of what we say, and we want you to remember it. So do take along notes, do record notes of the consultation, take the leaflets, and be proactive with your consultations. The other thing that many patients say, well, they didn't send me an appointment, therefore they knew I was fine. That's not necessarily true. There are coordinators. We're fortunate in macular degeneration. Most units have coordinators, and that is useful to make sure you get your appointments on a timely manner. So, in summary, the future, I think, is incredibly bright for retinal eye diseases. There's a large number of consultants that are working, there's a large number of scientists that are working on it, and new treatments. And the real effect of that is that where I am registering fewer people as blind or severely partially sighted, that is real. That's been recorded in the UK and in America. And I think we are now making a difference. And I think the future for this is very bright. Thank you very much for listening, and I'm very happy to take questions.